Hi, this is Dr. Frank Giordano. I'm presenting Abstract 2050, which is a poster on the interim data from the German multicenter phase 1/2 Gloria trial. We have plotted a bit of the background and the study design in panel 1, where we show what happens once you block CXCL12. We think that this abrogates recruitment of provasculogenic bone marrow-derived cells, and which also prevents T-cell exclusion from the tumor microenvironment. We use LOXA12 or lactosid pigol, which is an RNA spiegelmer that binds and neutralizes CXCL12. Here's an overview on the population we've included and on what we did in the trial. And basically we gave radiotherapy and in parallel LOXA12 in 3 dose levels. Here's an overview on the endpoints. You see that the primary endpoints is safety, and secondary endpoints, beside plasma levels, also some efficacy endpoints where we look into classical parameters, but also where we look with advanced imaging in these tumors to see what happens there. We have an exploratory endpoint where we show images from Codex multiplex immunofluorescence imaging. Panel 2 gives you an overview on the safety, and in a nutshell, that is a very, very mild safety profile. Not a lot. 3 of all AEs that are greater or equal to are A12 related, and you see that the max grade that we saw under A12 was a grade 3 event. In panel 3, we show some exemplary courses where we give the drug, when we deseed the drug, the tumor came back here, and in that patient, we also put the patient on the drug for 26 weeks and deseed the drug here. Per protocol, we wanted to go for 26 weeks. We thought that that would be enough. And after these patients, we basically amended the protocol, and now we can apply that for longer than 26 weeks, basically until there would be any case of unacceptable toxicity. That patient is quite specific here. That patient had a suspected PD. We performed resurgery, and I'm going to show you the multiplex immunofluorescence images in panel 6. What came out when we looked in this sort of mass here, which was later turning out to be pseudoprogression because there were no tumor cells in that. Panel 4, we have summarized the best responses of the target lesions of Gloria in a matched reference cohort, so target lesions of Gloria. You're going to see that 9 patients had target lesions, 1 had no target lesions of all the 10. You see that almost all patients responded to treatment very nicely, also 4 achieving partial remission at one time point under A12. And when you look in the matched reference cohort, it's a totally different image. If you look at the non-target lesions, you see a similar encouraging efficacy pattern. You see that even that 9 patients had non-target lesions, one patient had no target lesions. You see that 3 achieved complete remission and 4 partial remission. So that is a quite nice response to therapy. Looking at the advanced imaging, we have looked into fractional tumor burden, so the aspects of the tumor that are highly perfused, FTP high. You see a bit of a dose dependency. The higher the dose level, the more these fractions really decrease, the fewer the tumor is actually then composed of highly perfused aspects. But also when you look at the non-target lesions, you may want to think of a dose response, and if you look at the cellularity, it's also similar. So the diffusion, when we looked at here with ADC, is also yielding a bit of a dose dependency. In panel 6, we summarize the tumor microenvironment, the exploratory endpoint, and in a nutshell, we look at CD8 T cells. That is a quite interesting finding, and that is basically confirming the hypothesis that blocking CXCL12 will increase CD8 T cells, granzyme B positive, Ki67 double positive T cells in a tumor, and that was seen in 2 patients. And here in the lower panel, we looked into macrophages. You don't see really change in the number of macrophages, but what you can see is in a patient that did not respond to therapy, In the baseline, when you look at the tumor that is initially resected, you see macrophages are quite evenly dispersed all over the tumor. But in the recurrent tumor that was not responding to A12, you see a strange formation, a cuffing of M2-like macrophages, or an encapsulation of T cells by M2-like macrophages. So we think that radiotherapy plus A12 is safe. There were no DLTs. We saw really strong signals of clinical efficacy. We have in the tumor microenvironment evidence that we increase the number of T cells, so we can basically now recruit T cells into the tumors. They also cluster in the tumor, and then consequence we started expansion arms with bevacizumab and pembrolizumab now, and we're really curious what happens when we combine that now with these new therapies. Here's a QR code where you can look into the clinicaltrials.gov entry and get some more details on the protocol. Here's my contact email address, and email me if you have further questions, or see me at the poster in Chicago. Thanks.